Well, there's millions of social reasons why these patients can't be a day case. They've got to have a responsible adult with them for 24 hours post-operatively. They've got to live within an hour's drive from hospital. And traditionally, we had all these rules about inside toilets and telephones and heating and stairs. That's less relevant these days. So I wanted really to just talk about mainly the first one, because this is the biggest, thorniest issue that we find nationally, is what do we do about patients who live alone? Because traditionally, you live alone, you can't be a day case. And people didn't even think about it, they booked them as inpatients. And in BADS, we're really beginning to challenge that at the moment and say, is that the case? And I'm going to show you some examples and some work that's been done looking at how we manage patients who live on their own. So the first thing we looked at, and this was the work one of my registrars undertook, and it was saying, okay, we say that patients need a carer for 24 hours post-operatively, but how long did the carer actually stay, and how long did the patient think they needed them for? And we stratified the patients according to the procedure they had, and it was whether the procedure was predicted to have no pain post-operatively, mild pain, moderate pain or severe pain, and that's how in Torbay we stratify our procedures. So the no pain procedures are obviously the more minor ones, your cystoscopies, etc. Your severe pain are going to be your hysterectomies and your really major surgery. And if you look at the graph, most of our patients actually behave, or at least they lie and tell us they behave. So most patients, the blue line on the left shows that the carer did stay for 24 hours. However, if you look at the dark blue line, you see that the patients having more minor surgery felt that within 2 hours they were back to their activities of daily living, and that actually within 6 hours they felt safe and didn't need a carer. Whereas the patients who were having more significant surgery, understandably, felt they needed the carer for longer. And when we asked them as a percentage whether they thought 24 hours was too long or not long enough, in general, 30% thought they didn't need people for 24 hours, 60% or thereabouts felt it was about right. But again, if you look by procedure, if you had a more minor procedure, you were much more likely to think that you didn't need a carer for as long. If you had a really significant procedure, you were more likely to need a carer. So that made us begin to think, actually, do we need to be looking a little differently and saying that not all procedures are the same? So we came up with a few solutions. In Torbay for a few years, what we've been doing is if a patient doesn't have a carer, we provide a carer into their home. So they stay in the day unit till 8 o'clock in the evening. They then get taken home by hospital transport, and a carer meets them on their doorstep and stays with them overnight. That carer doesn't need to be trained, because if it was their wife or daughter, they weren't trained. They just need to be a responsible adult in their home. Some patients are excluded. If you live in a bed sit and there isn't a separate room for the carer to sit in, we had someone who lived in a caravan. If you've got significant mental health issues or history of violence, obviously that's not appropriate. And we've got some work showing the very positive feedback from the patients who had these carers. King's Lynn have a different system. They have what they call a virtual ward, so they send some patients home alone, but have them on what they call a virtual ward round, and those patients are phoned 2 or 3 times over the 24 hours to make sure that everything's fine. And Norfolk and Norwich for some years have been sending specific patients home with no carer. So if they've had non-body cavity, non-airway surgery, so we're talking dental extraction, cystoscopies, hysteroscopies, then they allow them to go home if they are happy to do so without a carer. And at Torbay, we've just blatantly stolen the Norwich protocol and adopted their protocol as well in Torbay. So it just shows there are different ways of looking, and this is now very much endorsed by BADS. We've published this work, and you wouldn't be an outlier if you began to adopt some of these models. The important thing to clarify, though, is escort versus care. We still say that a patient should be escorted home so that someone in the world knows that they've had surgery, and also is able to help listen to the instructions that the nurse gives them, so that if they then can't remember the next day what they were told. So a lot of people can have someone who will pick them up, but not someone who will stay with them. Distance from a hospital we've already touched on, and I think my message there is I come from Devon, which can be quite rural. That was mid Wales, but even there most patients are within an hour of a hospital. It doesn't need to be your hospital, it needs to be a hospital that could deal with the complications of the surgery they have had. Now I appreciate if they're in the Outer Hebrides and you've got some really distant sites here that is different. But most patients aren't, and it's very easy to skew your arguments or have people trying to skew arguments for you. And you say, okay, they are the exceptions and we need to think about something for them, but most patients are not. The one thing I would say there, we've touched on tonsils, and our guidance is for tonsillectomies, it should be 30 minutes rather than an hour, and that's because of the risk of catastrophic airway bleeding. So we do want the tonsillectomy patients to be able to get back to a hospital with an ENT surgeon within 30 minutes. So basically, if we're looking at social factors, most patients are appropriate for day surgery or can be enabled to be so by putting pathways in place. I think you're right, and I think there's huge nervousness in the ENT community, or has been traditionally, about tonsillectomies. However, the goalposts are moving, and traditionally we always kept these children, well, adults, but these patients for 6 hours post-operatively. The guidance now has come down to 4 hours, so that's beginning to relax things a little bit. And the reason for that is that the evidence about primary hemorrhage is that it happens within the first 4 hours or at 48 hours. And if it's at 48 hours, they'll all be home anyway. So it's tricky, and your chances of needing to get back in a hurry after 4 to 6 hours are very low. I think there's just still nervousness about the consequences of if there is a bleed and you can't, and there's a traffic jam. I think you have to look at your community and your roads and whether 30 minutes is likely to become 40 or is likely to become an hour and a half at rush hour. The other thing we say, particularly for children with tonsils, is that if they have siblings, there must be 2 parents so that one can grab and run. What you don't want is them needing to come into hospital and phoning round for childcare to come and look after the other kids. So they have to both be at home so that one can stay with the others and the other one can get in the car and go, rather than have that half-hour delay where they're trying to organise where the other child can go and this, that and the other. So I think it is a challenge. I think the ENT community have been rightly nervous, but we've now been doing this for 15 plus years. If you go to somewhere like Epsom, where they've got 100% day case rates for their tonsillectomies, they've been doing it for an awfully long time. And in fact, when we were struggling to get day case tonsils in 10 plus years ago, we went down to Epsom and just nicked everything they did and copied them. And I suspect they would be a lot more relaxed and lax. I think if you're struggling with it, and if you're struggling with your surgeons, to try and push them too far will break it potentially. But I appreciate in some regions that 30 minutes does limit your resource. I have, because we've got a local prison, and it can be a real challenge. The thing that we've recently come against, which I have significant issues, is getting these patients their medication, because after a certain time of day, the medical team go home and the patients aren't allowed to have their medication in their cell, and it suddenly becomes clear, actually, they get no medication from 6 o'clock at night until 8 o'clock in the next morning. I think that is not acceptable. So we're working with our prison governors at the moment to say, you know, because it's in their best interest. They don't want the patient in hospital, because if the patient's in hospital, they've got to have a guard in hospital. And so they want to make day surgery work. So we're now saying to them, you've got to work with us, but we're not sending patients home after a lap chole and all they can have is paracetamol because you won't dispense anything else. So, but it does involve communication, but it's almost selling it to them. Say, okay, you know, you can either organise a way to get some cocodamol and brufen to these patients, or you'll need to put an employee in the hospital overnight. It's probably easier for them to have someone go back to the prison at 10 o'clock for half an hour and dispense the medication than have someone in hospital all night. So it's trying to find a way. But that, I only became aware of that in the last 6-12 months or so, and I was quite shocked. But it is tricky, and they are a challenging group of patients, but we have a lot of them through our day unit because we've got a local institution.
That's great, thanks very much.
The other tricky thing with those is that some prisoners aren't allowed to be told until the morning of surgery because there's risk of escape, etc. And that's really difficult in terms of starvation instructions, but also preparing. I do feel that, you know, our duty of care to these patients can sometimes be a little bit compromised, and it is tricky. I think the more you can do it, the better. There's no doubt about that, and the more you can get the patients feeding into your literature and being your advocates, the better. We don't have a huge amount in Torbay, but we have got now on BADS Council 2 really good lay reps, and they're beginning to, so they're our patient representatives, and they're beginning to write some very good literature that we're getting onto our website from a patient perspective. And I have to say I'm really impressed with what they're coming out with, and it's great to be able to read stuff that's being written by lay people for lay people, rather than us being a bit more paternalistic and giving them the information we think they should have, rather than them writing the information of actually what I want to know is this. So yes, we're just developing what I hope is going to be quite a good patient section on the website, so watch this space.